And so we're recording now, and now I'm going to go ahead and broadcast and just start welcoming folks.
Great.
Greetings, everyone. Welcome. I know some of you are getting logged in and joining us. And so we'll just relax here for a little bit as folks get settled in. And Lee, I'll just check in with you. Hopefully on your computer screen, you can see our full screen of the business model for BH integration.
Absolutely. Good to go.
Okay, great. And Lee, it looks like we got a bunch of folks logging in right now, so just want to welcome those folks who are in the process of joining us to our webinar, the business model for BH integration. And we're just going to give folks a few more minutes to get settled and get logged in. For those of you joining us, I'll be repeating this a few times, so bear with me as we orient our new participants as they come in, but just also want to welcome folks to utilize our chat. We have the webinar chat where Lee and I will do our best to kind of monitor that and integrate any questions or comments or thoughts. We really love it most when we have some interaction. And then you can also use the question section of the webinar feature, and so we'll watch for any questions that come through that. But the chat's probably the most helpful way for us to all try and stay connected. Oh, we got a hello from Jeremy Rutherford. Jeremy, so glad you could join us. Good to see you. Or, well, at least read your chat. Lee, why don't we go ahead and looks like we're a couple of minutes after 1 and we got a bunch of folks already logged in, and I know folks will be joining us because as you know well, most of them are working in health centers and probably scampering back from sessions and doing the work that we do. But I just want to go ahead and get us started. Greetings, everyone. Welcome. My name is Nick Shubiak, founder and integrated health consultant here at NSI Strategies. And this is our webinar today on the business model for behavioral health integration. I'm really excited to be joined by my colleague and friend, Lee Ruszczyk. Lee is the behavioral health director at Henry J. Austin Health Center in New Jersey and has been doing some incredible work. We've gotten to know each other over the years. and have connected through places like the Center for Integrated Health Solutions, the SAMHSA HRSA Center for Integrated Health Solutions, and some work at the National Council together. And so Lee, welcome.
Good afternoon, everybody.
So Lee, I'm going to go ahead and just start us off with some housekeeping, and then we're going to go ahead and dive into the good stuff for why everybody's here today. As a reminder, for anyone who's attending or couldn't make it, a recording of this webinar will be available. And so we will be sending you an email with a link to the slide deck and also a webinar recording, so you'll have that. Also want to encourage folks, we have a pretty cool newsletter that we started up this year that really includes cool tools specifically focused for the work that you do at your FQHCs in integrated care. An example to your right is the 2-sentence curbside consultation, a tip for doing curbside consultations. Also, past webinars and other resources are available on our website. Again, reminder, we have a bunch of folks that just joined the webinar, so welcome to all of you. Questions and comments are welcome. We are all the experts here doing this work, and so we love your feedback and participation in the webinar. I'll be doing my best to monitor the chat box and to integrate your comments or thoughts or questions. And then after the webinar, we're just going to ask, there's going to be a quick pop-up of 3 questions, take you a couple of minutes. We really appreciate your feedback on those questions. It helps us tailor the webinars and tools that we build to make sure that we're giving you the support that you need to do the work. And then if you want to discuss this or any other aspects of integration, please don't hesitate to reach out to me at my email is there. You can text me or call me. And if you want to talk with Lee or myself, you can reach out to me and we'll be happy to make that happen. So enough of that stuff, Lee, let's jump in. And, you know, Lee, we talked a little bit too about really not wanting to do a webinar, but really wanting to have a discussion around this complex topic. And so for the audience, we just want to let all of you know that Lee and I decided that we're not going to be heavy on content, and we really want to dive into specific pieces of how you can build your health center capacity to build a sustainable behavioral health model at your health center, and really get into the nitty-gritty of what you have to think about and how you have to do it. So Lee, I'll kick it off to you. You know, we broke this slide down, but maybe you could talk to us a little bit about why we split things between, excuse me, the medical team and the behavioral health team, and how you build that integrated care team.
So basically what we decided to do is really look at how this is actually going to happen. And one of the main things that really kicked us off, and I'll be sharing a lot of how Henry J. got started, is our senior administration truly believed in the model of integration. And I really believe that's a must, because you can't build the buy-in from the bottom down, but really need to build it from the top down. And the fact that our administrator took a very strong stance with all of the providers in the agency, really saying that this is the way we're going. And if it didn't fit for their practice style, that was okay. And through the years, there's been a transition for us. So having administration have a buy-in and really believe in the model is something that is key, as you guys are going to or are attempting to build integration into your healthcare systems.
Lee, and you know, admin buy-in, right? Like, are there any things that you could suggest in terms of, like, how do you get that buy-in? Because sometimes we, you know, what we mean by buy-in is that we have a medical director, or we have a CEO or an executive director that says, yeah, you know, we support integration, we're doing integration, but sometimes we need a little bit more than just support. And just curious, does anything come to mind in terms of how you have been able to build those relationships with those key leadership roles of medical director and also CEO, executive director folks?
So I think the key for us is that the CEO and the CMO have a very strong belief in how care is delivered. So they learned about the model. They saw it in action. They received some training. It's very client-centered, client-focused. It is very much about working together as a team, and they hold that philosophy of practice. And I think that that's been key, is they really see the value of practicing this way and the significant impact that it has on the patients to be treated in a holistic manner.
Mm-hmm.
So I think that learning about it and really recognizing the value of it and having a belief in providing care this way was really key for the senior administration.
Yeah, it's such a key piece. And I think that then starts to trickle down into where we were moving in terms of talking about getting buy-in from the medical team. And again, right, we're not talking about, like, everyone for the most part says, okay, yeah, this is a helpful thing. But what we're talking about is really elevating that level of integration. And so we listed here a couple of key pieces that we think are really important to start with the medical team in terms of how we start to shift that view of behavioral health.
Yeah, I think that that's key, because I think that everybody is bringing in, from the medical team, for the most part, an understanding of that means mental illness and substance abuse.
Right.
So initially that is really, and they found that very valuable, because there are complex patients who come in who struggle with these issues, but behavioral health is so much more than that. And it really was about really demonstrating to them in their day-to-day functioning where behavioral health fit and how it was going to be beneficial, not only to the provider, but to the team. And since everybody who's working in healthcare really has that belief in what they're doing, that they actually could see how it benefited the patient. So all of those factors, really working towards accomplishing that understanding of a chronic disease. You know, if somebody's not taking their medicine, you know, what's getting in their way? What are the social determinants? It's not that they're non-compliant, but there are maybe a lot of barriers that are getting in their way that prevent them from actually taking their medication. So just really building this social determinant, patient understanding, and patient-focused philosophy for the medical teams was key.
I love how you point that out too, right? Because it's great that in the integrated care environment, we have behavioral health to support some of those traditional behavioral health issues. But the integrated care model is calling behavioral health to also utilize our strengths to not just address when someone is depressed or when someone is having an emotional reaction in an exam room. We have tremendous value when it comes to impacting behavior change. And like you said, that is so key for impacting chronic health conditions. And I think that's part of that buy-in that we're talking about, Lee, right? Where it's shifting the medical team to thinking of how behavioral health can be so effective in treating some of those physical health, chronic health conditions.
Yes, and I also think that it helps for them to begin to view the patient in a different light, to really understand that people for the most part really want to do the right thing and be healthy.
Right.
There's so many barriers and complicating factors that get in their way of achieving that. And how can we help them through that as they want help? Rather than prescribing to them, how do we collaborate with them and work together for them to achieve their goals?
Yeah, and Jeremy just put in the chat, Lee, he says, he agrees that behavioral health is a large and broad topic. And he said sometimes for him, it's hard to boil down to what we do in a clear and concise manner to medical providers. And I think you were getting to this. He's saying, do you have any thoughts on how we do that or how we say that?
So one of the things we started with is we really spoke to the provider and the medical team about those patients, and we all have them, that come in and they want to talk for half an hour and 45 minutes. And we all understand that our providers don't have that bandwidth. And it really was showing to them the value that we could go in, since we are very much trained in motivational interviewing and keeping patients focused, to go in and intervene prior to the provider and really narrow down what the focus is so that the provider can do what they do through our assistance. So it's those small things, people who may be struggling with their medication or following through with a referral, you know, helping them figure out how to accomplish these small things step by step, so that way they start to see the change in the patient and become less frustrated, and the patient becomes more successful. So it's just very small things rather than this large, broad category. So it's taking the individual patient and saying, okay, what does this individual patient need? How can I help them do this piece by piece?
Lee, that's awesome. And I love how you said that, because, you know, I agree. I don't think there's any one real big thing that's going to shift this culture shift, right? What we're talking about this entire time is all of us stepping out of our traditional roles, responsibilities, and training. So it's by its very nature a little threatening and scary and challenging. And so it's by modeling what Lee's talking about and demonstrating our value. And I think that we're going to also have some additional slides coming up that are going to show some of those other ways that behavioral health can demonstrate their value, and some tools that are helpful in helping also integrate behavioral health into chronic health conditions. One I think of off the top of my head, Lee, is one of the things that we did at our health center is that we had and partnered with our medical director to write a standing order that any of our patients with an A1C score over 7 would receive a warm handoff, would get a warm handoff. And it was a great way to use policy, procedure, and clinical pathways to start to help support the integration of behavioral health into addressing those chronic health conditions.
Exactly. But I think the other thing too, to transition, I think that's going to be really, you have to be very mindful of who is going to be the behavioral health team, because that is going to make a huge difference. And what type of person is going to fit within this model. And I think that's going to be key, because that can really make a huge difference.
You mean the behavioral health clinician, that person?
Yes.
Yeah.
Mm-hmm. I think that's going to be key, because the behavioral health clinician really is going to have to understand how the medical team works in order to communicate effectively with them. And I hold my team responsible for managing and intervening with the medical team. I believe that's our strength. That's what we know to do. We can adjust in environments. And I think that the team needs to be able to be the linchpin for the medical team and for this integrated team.
Is that what we mean? Is that one of the things, Lee, that you talk about in terms of like the behavioral health clinician needs to be proactive? That, right? And it's really shifting us out of that old model of like sitting back in an office and, you know, patients coming to us versus us entering into the primary care milieu and being an active team member.
And it can be very uncomfortable, because there is such a difference between the primary care model and the traditional behavioral health model, that it really is going to take a clinician, behavioral health clinician, who has that ability to be flexible, to work on the fly, to just go with the flow, because they never may know what's behind door number 1. It may be that they come up for, you know, depression, but there is some sort of trauma the patient experienced. So it really is going to involve that. And
Lee, I just jumped ahead because we're getting into this slide a little bit. And we can go back, and I love how you say that too. You don't know what's behind door number 1. I mean, that's part of the stress of being a behavioral health clinician who is doing warm handoffs, is that you are walking in cold sometimes, maybe a little bit of information because you have your EHR, you're able to read those notes and look at those things, look at the things in the chart. and maybe you get the opportunity to consult with a medical assistant or the primary care provider themselves. But beyond that, you're walking in there pretty cold to meet someone maybe for the first time. So it does start to speak to how we have to think about how are we going to train our behavioral health clinicians to adapt to this model to get maximum effectiveness out of it. And so, Lee, we put this slide together. It's a little bit about some of the things, the qualities that a behavioral health clinician needs, or we need to think about to prepare them in adapting to that primary care milieu.
Right, and one of the, obviously we already touched on it, one of the key things is speed. You know, with 15-minute visits, this is very different than the traditional model. It involves looking at staff members who can think on the fly, who are good with a changing environment, who are really, really flexible, and can go in within that time frame and really take a look at the patient, evaluate, and move forward. So I think speed and flexibility is going to be key in that role. And it's a very different role. And when hiring for it, I try very hard to really deter behavioral health clinicians who may be more traditional in their thinking. They are not going to be a good fit. If that's their philosophy, that's great. It's an excellent treatment philosophy. It does not marry well in the primary care setting. And
that's tough on us, right, Lee? I mean, you know, our licensed clinical social workers and psychologists, and we're going to talk about why I'm just using those two disciplines in a little bit.
Yes.
They're hard to hire. They are difficult to find. And now you're telling me also that of that pool, it may even be more limited. But I think it's a really important point to make sure that we have the right people in the health center with the right qualities and characteristics that are going to be able to support this model. You know, and some of this stuff that you're talking about certainly is personality and character and professionalism. And then some of it is trainable. You know, some of these things on here, like I look at language. And one of the things when I started at our FQHC, I felt like I was back in kindergarten again in a lot of ways. I had had years of clinical experience, but I couldn't understand what anyone was saying because it was all physical health primary care language. So I didn't know what an A1C score was. I didn't know how to read lab results out of an EHR. And those were language and skills that I needed to kind of build up my capacity to understand to help me start to fit in.
Yes, but the key with that too is it's going to be really important for your practitioners to have confidence that even though they're in a medical setting, that they are bringing their expertise to the table, and it is as valuable as the medical expertise that is in the health center. And
I love it. Yeah.
Believing that you are bringing in expertise, that it is just as important, and conveying that, which is very different for behavioral health. A lot of things, whether we like it or not, can seem very hierarchical. And I think it's really important to understand that it's not. It needs to be team-based, and it has to be collaborative, and everybody brings their expertise into working with the patient.
Yeah, Lee, it's one of the challenging things. I love how you explained it. It is hierarchical. We bring that history in of automatically deferring to the doc, right? And we do that professionally, and also, quite frankly, I think that happens culturally for a lot of us as patients. And the integrated care model is challenging us to push beyond that cultural norm. And on an integrated care team, the person who takes the lead fluctuates. It may be at any time, maybe the primary care provider, but like you said, the level of expertise that's needed at that given point for that patient may be with the behavioral health clinician. And so it's the sharing of that space with respect to the hierarchy, but sharing that leadership role that we know can flex in and out. Or Lee, right, we talked about this also, how maybe it's the community health worker or the patient navigator that takes the lead because they have a stronger rapport or connection with the patient and what's going on in that specific time.
Right, and I think that's key. Is it doesn't matter who's taking the lead, as long as everybody's bringing their expertise to the table and respectful, and realize that they're going to integrate all of this knowledge into the specific situation for the patient to benefit the patient.
And Lee, also we've learned, because we've seen this model work, our docs love it. The PCPs love it, because they don't, oftentimes I think primary care providers, they feel alone on an island, as do behavioral health clinicians. They're always in charge and have to handle everything. This truly wraps the patient around, it puts the patient in the center who's driving the decisions, and everyone has shared decision-making in this way, where we share these roles and take so much of the pressure off of any one of the individuals from operating kind of alone on an island, so to speak.
We, just a real quick story, we had a patient come in and they saw the medical provider, they saw the behavioral health, we have clinical pharmacy as well. We explained this all to the patient, and the patient walked out, they were like, I have a team. I have a team. They thought it was the best thing because they have all these people who are working with them and for them to make them healthy.
Fantastic. Yeah. And, sometimes I hear too, and, we'll get into a little bit, maybe this in more detail, but, patients don't want behavioral health, or patients get upset when behavioral health maybe leaves a room to go do a warm handoff. When in fact, the experience that I've had in working with health centers across the country, and we've talked about this, is that the patients are really okay with it. They love the model. It's the providers who are struggling to adapt to the new way. This makes total sense to them, that everybody's talking to each other, everyone's sharing one chart, that I don't have to repeat myself over and over again as a patient. How many times have I experienced that with my own healthcare? And so, it just speaks to how, when this model gets running, it starts to generate a new level of energy, not just for the patients, but also for the team, taking care of our exhausted and overworked workforce.
Exactly.
So, Lee, a couple other things on here, since we're in this slide of adapting to the primary care milieu, that we probably want to think of in terms of training our staff is we talked about being proactive. You gave that example of how your staff, they're expected to be switching from that reactive role and really being proactive. That may be showing up in huddles, or like we talked about, actively going in and talking to patients who maybe have an A1C score over 7, or whatever health condition it is that you're maybe looking to target. But it also means that we have to strengthen that behavioral health staff. And again, this may go into part of what is trainable, is really understanding how I can do a psychotherapy session in 20 minutes, how I can do a short-term brief intervention, how I can come up with a diagnosis, and my ability to be able to do that and train to do that is also a key aspect of supporting the model.
Exactly. And that's where the flexibility of thought process is really key as far as staff, is you need staff who are comfortable with not having their I's dotted and their T's crossed. They need to be able to identify symptomatology very efficiently and effectively when they have a conversation. So that way they can pick up the signs and symptoms of the diagnosis and be comfortable with the fact that it will be a working diagnosis. And as you see the patient, it may shift based on additional information that you gather. But it's going to be key for the clinician to be comfortable in that role. The other thing too is that we're asking them to compact the traditional therapeutic model to engage, which is key. So engage, assess, evaluate, contract, all within 15 or 20 minutes.
Yeah, it's a lot.
And those are skills that can be taught. It's going to be key to have an open workforce that wants to learn that level of intervention.
Yeah, so Lee, thanks. Yeah, and so it may mean that we have to dedicate training to, and I think social workers, quite frankly, are a little weaker in this area than psychologists in terms of understanding and having the confidence to diagnose. And it means that for me to generate a billable encounter, I got to be able to diagnose, and that may mean I need to train my staff on DSM criteria. And then also how to document that, right? And one of the essential skills for our clinicians in this model is learning how to do collaborative documentation, concurrent documentation with the patient in the room, using an EHR with the patient, how to do that, which is a much different skill set. And then also documenting in a way that more matches and aligns with how we write in primary care, which means breaking away from some of the traditional ways that we document in behavioral health. And what I'm trying to say nicely is that we write too much historically.
Yeah, the key is going to be succinct and fact-based.
Yeah.
Because your primary care doc isn't going to read everything you write if you're not succinct and fact-based.
That's right. I mean, I can write a great, fantastic, 1-page, 2-page note, but if no one reads it, it's not helping anyone, right? So how do I take that 1-page note and know how to succinctly capture the key elements that my primary care and my integrated care team need to know? And so that's another consideration for us too, because documentation, I think for a lot of health centers, we always hear it about those notes that aren't finished. And also, I think it's a key piece to burnout and exhaustion in our staff of folks, documenting in off-hour times during lunches, staying late, coming in early, and all the things when they need to be resting up, they may be dedicating to trying to get those notes done.
Exactly.
So Lee, maybe we'll move ahead a little bit and move into the sustainability piece. We talked about kind of the essential skills of the team, of the things that we need to think about for supporting the model. Let's dive in and talk a little bit about some of the nuts and bolts around sustainability.
So one of the things that's going to be key is everybody is going to need to understand how their state reimburses, because there's no federal rule on reimbursement. It is going to involve you understanding in your state with your Medicaid, can you bill for primary care and behavioral health on the same day? You're going to need to find that out. You're also going to need to find out what codes are billable, under what licensure level and provider. So for example, in New Jersey, in the FQHC, we are reimbursed for licensed clinical social workers for behavioral health and a PhD clinical psychologist. That is at LPC, at LCA, other credentialings for us in New Jersey are not reimbursable at this point in time. So that's going to be key to understand what licensure level is reimbursable in your state with your Medicaid rules. So that way you can make sure you can sustain the model.
And Lee, this is just such a huge point. We ran into this in our health center because, let's just say it, this stuff is really complex and it's really confusing. And sometimes it's really tough to get clear guidance.
Yes.
For all of us across in all the different states that FQHCs are operating in. And so, we ran into this problem. We had some very talented, wonderful, licensed marriage and family therapists, marriage and family therapists. However, we found out that we couldn't bill for them. And it really put us in a difficult position because they had relationships with patients. They were a part of the community, a part of the treatment culture. And we found that it just wasn't a sustainable model for us. And so really making sure that, and thinking about also too, if we bring folks on for special grants, even if they're licensed and being paid by a grant, is that a sustainable approach? Knowing that after that grant money runs out, they may not be able to generate the same kind of revenue that licensed provider, like you described, is able to generate. So I didn't mean to cut you off. I just really want to emphasize that point.
That's okay. Andrew is asking a question about, how to get efficient and up-to-date information regarding Medicaid. And what we were able to do for us is we identified the key players in our state Medicaid office, and we had regular meetings with them regarding our reimbursements and what we were being paid and how much we were being paid and if we were being paid, and getting all of the ins and outs, which they can tell you but it typically takes persistence in direct meetings. You're not going to get it through having a phone call with Medicaid. We really sat down, and our primary care association was key in helping us get this accomplished. So I would, if you're in an FQHC, I would tap in your primary care association to be able to help you advocate and gather this information, because ours has been absolutely key in helping us understand the licensure, the codes, how it got billed, all the ins and outs that we typically don't know until we've submitted it about 10 times to find out we haven't gotten paid. So the face-to-face with the people and the players was very, very beneficial for us to get this stuff accomplished.
Thanks, Lee. Yeah, Andrew, great question. And Lee, I just jumped ahead to one of our other slides here. One of the resources that I think is helpful, this is a document that NAC put out. The link is in the PowerPoint slides. We'll send this out to you all. I tried to get it into the chat, but I couldn't highlight it for some reason. But this is a document that really goes through what codes are billable in your state. And so we'll go ahead and as we get further along into this and take a look at that, but we will, Andrew, we'll make sure that you have access to that link. So thanks for asking for that.
The other thing too is it's not necessarily what's billable as much as what's turned on. We found out that in our state Medicaid that while certain codes were billable, they were not turned on in the state Medicaid system. So that's why sitting down and having the face-to-face conversation to find out what can we bill, what's the licensure, are the codes turned on, what's the what's the reimbursement rate, are key. So just because it's billable doesn't mean it's going to get paid, because it might not be turned on in your system.
Lee, that's a great point. On the slide that hopefully is up now in front of you, that point that you just made is right here, right? So a perfect example of what you're talking about is that this code, for SBIRT billing, the SBIRT codes in Colorado, if we look down, which is the third line down, the states approve the SBIRT codes. Great. So that means those codes are approved. We can use them. But the problem is that on the right-hand side, those SBIRT codes in the Medicaid system are not turned on. And so you cannot receive payment. So again, back to our original disclaimer here, this stuff is complex. And so it really behooves us to be vigilant and ask a lot of different questions around setting up our models of what we're billing, who we're billing with, and what diagnosis codes that we're using.
And we're trying to give you some of the lessons learned, so that way you don't have to find them out the hard way. So you can go in and say, okay, so is this billable? Is it reimbursable? I can tell you in New Jersey for the SBIRT is that we get a specific rate. So it doesn't matter how many different codes we use, we get the same rate regardless. So it really is very valuable to understand how this system works, where your state is at with it, and to contact people who can answer your questions.
And Lee, to even make it more complex, right? So it's kind of asking the question, can I bill for behavioral health or primary care on the same day? If I can, what codes can I use? What are billable? What codes can I use? And if those codes are going to get me reimbursed? So that's another 2 questions. And then associated with those codes, what diagnostically is reimbursable, which may differ from state to state. I may be able to bill for generalized anxiety disorder in New Jersey, but I can't do that in Colorado. And so knowing those, that's another 4th question. And then I think a 5th piece, Lee, is your own agency licensure, and understanding that, how an FQHC license in a certain state can be different than, say, for example, we talked about having a substance use disorder IOP license.
Right. So for us in New Jersey, our agency is licensed as an ambulatory care program, which means that we're not allowed to provide IOP level care. In order to do that, we would have to submit for whether a mental health license or a substance abuse license. So understanding the state licensure process and what that means regarding your agency and the services you can provide and what you can bill, and all of those types of things are going to be key. So the more information you have on licensing and coding and diagnostics, it's going to be much easier.
And I think, Lee, your suggestion of, proactively reaching out to your primary care association, but also something that we don't do, I think enough, and it sounds intuitive, but it's not, is also to reach out to your colleagues in your state, the other FQHCs, your other BH directors, to talk and to share what's working, what's not working. The shared learning of our FQHC community can be so valuable. And so developing those networks and those support systems can be really critical in helping save a lot of time. The other thing, like you said, is sometimes you got to try it. And so that means putting through a specific scenario according to these 5 questions that we talked about through your billing system and seeing what happens, tracking it, monitoring it, taking a look at it, seeing what gets paid, what doesn't get paid, why or why not. We're going to get into a little bit of that in a second. I'm going to jump ahead, Lee. The good news is I wanted to throw this slide up, is that most states do allow same-day billing for both behavioral health and physical health. And so these are the states in yellow that allow it. There's some variation in some of the other states, but for the most part, we can do this. And there are some exceptions to it. And one of the things that we're going to talk about in a minute is a little bit of a model of how this might look. And when we talk about that model, Lee and I decided that we would focus on pretty much these top 4 codes on the right-hand side of the sustainability slide that you're looking at right now. And the reason behind that is that we know that these codes are psychotherapy sessions that also include reimbursement through your PPS rate. And so we want to make sure that we maximize using these codes in a way to generate the most revenue for our health center, but also to make sure that our patients are getting the maximum care. We've heard a lot about the 9600 codes, the EMB codes that were actually designed to support integration. There's some challenges with those. A lot of states, you can only bill for those if you're a licensed psychologist. You can't bill for them if you're an LCSW. And the other challenge is that most states do not reimburse with that PPS rate. So Lee, just throwing that as a teaser, we're going to move along a little bit. I think we kind of covered this area because we jumped ahead a little bit, right? About making sure, was there anything else we wanted to add in there?
I'm not sure if this is in another slide or not, but I think what's going to be key too is you need to have, so your standard medical coding and billing person might not be sufficient. You need to have somebody who specializes in behavioral health reimbursement. I know for us, sometimes it gets sent to different places, to different parts of the healthcare system. So having someone, whether it's even a state consultant who is aware of how to get this done, is going to be key. The other piece of it is how are you contracted? What do your contracts say? That's going to be key, okay? Do you know what you're allowed to provide? How much you're being reimbursed? Are your contracts for your different healthcare systems, whether it's Medicare or Medicaid, are they up to date? Or were they negotiated in the 1990s and they haven't been touched for 20 years? So that is also going to be key to make sure that all your people are appropriate credentialed with the healthcare companies that you participate with. Your contracts are up to date. They include your reimbursement rates and your codes for reimbursement. In addition to knowing what gets reimbursed, how it gets reimbursed, how do you bill it, and all the ins and outs.
Lee, and that's such a great point. The complexity of this also is that we want as much to make sure that we take this component of it away from our behavioral health clinicians so that they can focus on the integrated care model and that we have these systems set up for them. And I think one of the ways that, you know, we can use as a guide is really understanding that Medicare and Medicaid set the kind of set the rules. That's usually a good guide for us to go by. They set that list of providers in our state that can generate that reimbursable encounter. So that's a good place for us to go to find out that information. And typically the way those federal laws are written is that, like Lee said earlier, it's really only LCSWs and licensed clinical psychologists that can bill in an FQHC to generate that PPS rate. However, there are some states that have amended that. And I think Vermont's one of those states that allows other master's level licensed behavioral health professionals to be reimbursed at the same rate as LCSWs. So there are exceptions to the rules. And Lee also brought up how we can reach out to our state Medicaid offices, how we can connect with our primary care, our state primary care associations to start to help amend these rules. A lot of these rules, Lee, I think you'd agree, were written in a way where they don't necessarily take into account what we do in integrated care.
No, they were developed prior to the concept of integrated care. And unfortunately, we all know that bureaucracy takes a long time to catch up to actual practice. So that is really why having people who are involved in the political end, the New Jersey, you know, our primary care associations, to advocate for us is really key, because that's really where we've sat down and done a lot of work with them to, you know, typically in Medicare, the H&B codes are not reimbursable. They are in New Jersey. And that's the work we do with our primary care association. So things can change. It does take time, but it's a face-to-face meeting, and having people who know how to gather the information and negotiate is going to be key.
Great. That's a great example of it, Lee, of kind of using, you know, sitting down at the table and making those changes to help support this new model. Lee, there were some questions in the chat. It looks like Dr. Duplantis needs to leave, and so she's asking, can she get the slides? I just want to remind everybody that did get in a little bit later that, yeah, we're going to be emailing you a recording of this webinar and also the slide deck. So you'll have access to all the information that you see in front of you. So jumping back into the slide deck and looking at the screen that's in front of us, Lee and I put this together because we wanted to put out the Cadillac version potentially of what the integrated care model can look like. And we both agreed that we thought this was important for us to do because, you know, our model of care, Lee, right, there's a lot of, no one's seen it, a lot of us. Like, we have not experienced it. And so how do you formulate in your head a model that you haven't experienced or haven't worked with? And so we kind of put this together, and Lee, I'm going to go through it, but jump in anytime if I miss anything or you want to add anything in, please. But this is a look at what would be ideal in maximizing a situation of a patient who comes in who, let's say, has diabetes and also scores a 20 on their PHQ-9. And their diabetes, their A1C score is high. And so the idea is that in day one, they come in and they check in, and to think about what opportunity do we have in the waiting room to start to set the tone for the patient's entire experience of care. So are we starting our screening process? What kind of forms? How does the front desk communicate to our MA, or how does the patient end up getting from the front desk to the exam room? Are we using a trauma-informed care lens in this beginning critical area of setting the tone for treatment? So in some way, in a typical health center, that patient checks in, maybe fills out some forms, does some screening, maybe does a PHQ-2 or a PHQ-9, and then moves to the exam room. And the idea is that, yep.
Before you go on,
Yeah.
You need to decide how you're going to maximize that patient's time when they're completing the forms. So we've integrated more than the PHQ. We do the PHQ2, we do the GAD2. We've done some minor screenings to open up so we can be able to pick up more things that the patient may be experiencing. And we've also normalized it so that it happens every single session, every time they come in to see the doc. So that way they expect it, it's part of their experience, it's not singled out, and it's just become normal.
Lee, that's such a critical point, not only for the patient, but for the staff, right? Because
Yes.
doing those screenings every time they come in, like you said, it normalizes it, and it also just makes it what we do at our health center. And so we see a lot less missed screenings when it's just part of the vital signs or the workflow or the clinical pathway. That's
Exactly.
such a key piece, right? The staff doesn't feel like it's one extra thing. And it also takes the thinking out of it, where how do we monitor if we're screening once a year or every 6 months or every whatever the screening regimen might be. Doing it every time, especially for our patients who oftentimes there is a level of uncertainty because of the social determinants that they experience. Their lives can change so quickly in a short amount of time. Screening in that way is so valuable. And not only that, Lee, right? That also starts to generate business for behavioral health.
Yes.
That's how I start to generate my 90832 encounter codes and being able to do a psychotherapy session right away with someone who might need it.
Exactly.
Great point. Yeah. So we're 5 minutes in and we didn't even get to the exam room yet, Lee. Okay. So we get our patient to our exam room and our primary care doc says, hey, I'm going to address your A1C score and your diabetes. I'm concerned about your PHQ-9 screener that came back high. I have available right now to talk with you this really cool guy, Lee. He's a behavioral health provider. I'm going to have him come in and talk to you. He's really fantastic at working with my patients on reducing their stress. And I think this is going to really help support you. And so in that way, the primary care provider introduces Lee to the patient, and Lee, as the behavioral health clinician, can come in the exam room, do an assessment, be able to bill for a psychotherapy code, maybe start some address and take a look at a history of depression with the patient. He determines that the patient's had a 5 or 6 year history of depression, and that 5 years ago, the patient was on Prozac and did really well on this medication. Lee's able to bill for that encounter and also consult with the primary care provider to say, hey, doc, I just saw the patient. Patient had a history of depression. There's no risk for suicide, but he has done well in the past on Prozac. Is that something you'd be willing to consider? Doc says, great, let's go ahead and start him on Prozac, but I want to see him back in two weeks to make sure that he's doing okay, and to follow up on that psych medication regimen. And I'd like you to also assess the patient as well. So in 7 to 14 days, we schedule an appointment, a medication follow-up appointment with the primary care provider, and also a planned warm handoff. And we've called them behavioral health integrated care sessions. And this is when the behavioral health clinician sees the patient, maybe before the primary care doc even gets in there, does an assessment, sees how the patient, if he's taking the medication, how he's tolerating the medication, any side effects, and then does a consultation with the primary care provider, who walks in and does a quick consultation, lays eyes on the patient, and says, great, we're going to continue on this medication regimen or adjust it as needed. And so the doc and the primary and the behavioral health clinician say, yeah, I want to see you back in 14, 21, 28 days. The behavioral health clinician says, great, I'll meet with you and the doc then, but in between then, let's go ahead and meet for what we would call traditional behavioral health follow-up appointment. And maybe that appointment is 20 minutes, maybe it's more like 45 minutes, where we really start to build on some of the cognitive behavioral therapy techniques or behavioral activation planning that I've started in those warm handoff and integrated care sessions, where I see them in a traditional follow-up session maybe once or twice. At this point, we're seeing that PHQ-9 score starting to come down because the patient's utilizing those behavioral health interventions, cognitive behavioral therapy techniques, but also the medication is doing its thing. It's starting to work. It's been being taken for 3 to 4 weeks, and we're seeing that PHQ-9 screening tool come down. So what we see here is the maximizing the patient's time, using a maximum amount of support when the patient needs it, which is in the beginning part of this treatment process, and getting all of this done under just a few visits, adjusting medications as needed, using an integrated treatment plan, also the coordination of schedules, having a schedule there who's able to help coordinate our schedules between the primary care provider and the behavioral health clinician.
The other thing too, just real quick, is that it's really, we found it to be very helpful if your medical provider introduces you as a team member who does behavioral health, not somebody who does mental health, because the answer we typically get is I'm not crazy. So it helps explain to the patient how you're viewing their treatment and that it's integrated and it's here to help them get better.
Lee, it's a great point. And I feel like in this model, I rushed through it because we're running out of time. There's so many wonderful nuances in here, right? That we probably could do a webinar on each component of the skill sets and the essential skills required, and how to set up your scheduling, to how do I make sure that I have a behavioral health clinician available to even do it this way? All part of the challenges of implementing this model.
Yep. Yeah, it would be a great webinar.
Jeremy's saying these would be great webinars. Great, Jeremy. Well, great. We love that feedback. Well, if I can convince Lee to come back, maybe we can do some more. And so, Lee, we're coming up on our time. I want to just jump into some of the, maybe in the last couple of minutes, if we could go over some of these health center pitfalls.
Right, so we've already touched on the contracts. Are your contracts in order? Are they up to date? Are you making sure your behavioral health services are covered? We also touched on the paneling to make sure there's so many different parts of healthcare companies. We just found out we thought we were credentialed and there's 2 additional places. So it's about understanding all the nuances with regards to getting and making sure that your behavioral health staff is credentialed. The other piece that we're also finding really helpful is that there has to be a financial feedback loop, okay? So when the claims go out and they're not being paid, do you know that? How do you know that? Do you get to know that you used the right code or didn't use the right code, or that this diagnosis is or is not reimbursable? So finance cannot live in their own bubble. They have to be able to provide feedback to the providers, behavioral health providers, on what is working, what is not working, as well as the FQHCs and everybody getting together with primary care association saying these are not being reimbursable, they should be. So there's got to be some feedback loop so people understand exactly what's going on.
Lee, thanks for that. Such a great point. We need that data in real time so we can adjust. You know, I've heard health centers not being able to answer these questions and doing this hard work, great work, and not getting reimbursed for it, you know, and not getting paid. And we need to get paid so that we can do all the awesome things that we do with those resources, like hire more BH staff, or maybe run different types of programs with those monies coming in. And so it's such a critical part of supporting this model and making it sustainable. Great. All right, Lee, I think maybe this is a good place for us to wrap up. We've thrown a lot of information at everybody, so we're going to go ahead and wind it down. If folks have questions in between now and the wrap up, please go ahead and type those in. Thanks for the questions that came in. Lee and I really enjoy the interaction back and forth. I want to invite everybody. Our next webinar is going to be on March 31st, from 1 to 2, and it's going to be utilizing the BH team, a little bit of a more specific, deeper dive into some of those training aspects of what our team needs to know to address physical health and how to impact physical health outcomes. So we'll go through some MI training and also some education around some of those physical health pieces that we need to know as behavioral health providers that we may not have had the training. The link to that is on the website, and so you can go ahead and go to nsistrategies.com. there's links to our newsletter, and also to make sure that you sign up for our next webinar at the end of March. Lee, thank you so much for taking the time out of your busy day to join us and share your knowledge and experience. As always, we always have a good time talking about this work that we love to do.
Thank you, everybody, for the opportunity to share it, and thank you, Nick.
All right, thanks, Lee. And another reminder, if anybody does have any questions, we do, after anyone that attended the webinar that wants to do a consultation call, we offer a free consultation call with you or your team. I've had folks set up the whole behavioral health department, and we can have a discussion about any aspects of this. And if folks want to get in touch with Lee as well, you can certainly email me, and I'll be happy to reach out to him. So thanks so much for everyone attending. Thank you ultimately for doing the amazing work that you do in the communities that you serve. And so thanks, and we'll be hopefully connecting soon. Take care.
Bye.